This sitting is resumed. Prior to the suspension from this honorable chamber was debating was in standing finance committee. To that we shall resume.
This house is now in Standing Finance Committee.
Madam Chair, Head 86, Ministry of Health and Wellness, $208,185,658.
Okay, we invite the Honourable Minister of Health and Wellness into the bell.
Madam Chair, may I have your permission to allow the members of the ministerial team to join me?
So granted.
Thank you.
Honourable Minister, you may introduce your team and begin your opening remarks. For 10 minutes, please remember to move the head at the end.
Thank you, Madam Chair. To my right is the Permanent Secretary, Ministry of Health and Wellness, Mrs. Janet Phillips. To my left is the Executive Chair of the Queen Elizabeth Hospital, Mrs. Juliet Bino Sutherland. And I will ask the Chair of the QEH to introduce the members of the QEH delegation.
Thank you very much, Honourable Minister, Honourable Chair. I have with me from the Queen Elizabeth Hospital, Mr. Anthony Harris, the Director of Medical Services, Mr. Adrian Hurley, the Director of Financial Services, Ms. Louise Bobb, the Director of Support Services.
And now I ask the Permanent Secretary to introduce the remainder of the Ministry's team.
Good afternoon. I have with me, right behind me, my Financial Controller, Ms. Andrea Mears, my Director of the Barbados Drug Service, Ms. Miriam Hines. I have the Chief Health Planning Officer, Ms. Bashina Chatterham-Nels, and I also have with me Mr. Danny Gill, who's the Finance Commissioner, Mr. David Leacock, who is the Director of the Psychiatric Hospital, and Ms. Karen Broom, who is responsible for the polyclinics.
Thank you.
Madam Chair, colleagues, as I give my opening remarks today, I do so in somewhat an unusual way by starting with two quotations. And these quotations were taken from a speech delivered recently by the Director General of the World Health Organization, Dr. Tedros. And I quote the first one: "This epidemic can be pushed back, but only with a collective, coordinated, and comprehensive approach that engages the entire machinery of government. End of quote. And the second one, and I quote, "This is not a drill. This is not the time to give up. This is not a time for excuses. This is a time for pulling out all the stops. Countries have been planning for scenarios like this for decades. Now is the time to act on those plans." And I start here, Madam Chair, because in spite of the several months that the ministry would have taken to prepare its estimates and its budget, in spite of the fact that we are here today to defend those estimates, despite the fact that we are here to give reasons for why we want to execute the programs that we desire to do for the next financial year, all of these things will be shaped in one form or fashion by the ongoing coronavirus 2019. This is going to have an impact on whatever we do going forward for the next financial year. But we have to do this, manage this as a ministry, without compromising the remainder of the healthcare system and the delivery of service to the people of Barbados. And in order to facilitate the delivery of this service, we have a large sum of the public purse that has been placed at the disposal of the Ministry of Health and Wellness. And this effort is a monumental one because we have to balance the continuation of the provision of health care as we know it with the uncertainties associated with COVID-19. But I'm very confident, having been with this ministry for the past 2 years, and particularly being a part of this team for the last few months that have been dealing with preparing Barbados for what is confronting us, I am absolutely sure that we have the experience, the expertise, the dedication, and the commitment that is being displayed by the Ministry of Health and Wellness team to be able to cope with all of this. I start the estimates proper by saying that the Ministry of Health and Wellness, if you look at the estimates, you will see that there's been a slight reduction in our estimates, but it is not a reduction that we are worried about because we have taken into account the fact that the government of Barbados has determined that some capital expenditure will be made on behalf of the ministry, the Queen Elizabeth Hospital, in terms of purchasing new equipment, and that has also been extended to the other hospitals and the other parts of the Ministry of Health and Wellness. We manage this budget recognizing the fact also that this year we gather in 2020 that the Hospitals of Barbados project would be the beneficiary, the primary beneficiary of the philanthropic efforts associated with regathering. We take this opportunity to utilize what has been placed before us to be able to do what is required by also becoming a lot more efficient in the way we do things, in the way we manage things. And we are strongly convinced that given what is set before us, that we can continue to deliver a high quality of health care to the people of Barbados. The past year saw us initiating several initiatives. Some have been finished, completed, others are in progress. And to be honest with you, there are quite a few, but I will mention a few. We started the development of our human resource capacity, recognizing that all the equipment and all the facilities mean nothing unless we look after our human resources. The commencement of the 24-hour service at the Winston Scott Polyclinic. The establishment of a healthcare finance commissioner who, in collaboration with the Health Economics Unit of the University of the West Indies, have started a costing study, and that is going very well throughout the entire healthcare system. And that is going to facilitate the development of a new model of healthcare financing for Barbados. We've also been able to provide universal access to emergency, primary, and tertiary care for CARICOM nationals, particularly those who have been residing in this country, some of them for decades, some who have made significant contributions to the development of our country, and some who actually have been here working and paying taxes but have been denied certain things because they did not have citizenship. We have also been given the opportunity to improve the healthcare system with the expansion of the Accident and Emergency Department. And I will speak to that briefly because I don't hide things. I thank the Honourable Prime Minister and Minister of Finance for making the funds available to us. We've been doing a lot of things in the hospital, and the hospital team will speak to those things. That in spite of the fact that we have not yet started this project in terms of the physical work, which will commence in a week's time, that we have been able to deliver a lot of things within the Accident and Emergency Department by reorganizing, and also remember that we were able to establish a minor cases unit and a short stay unit at the Accident and Emergency Department. We've also, after several years, been able to finally bring to Cabinet the organ and tissue donation transplantation policy, which was approved by Cabinet, and the accompanying guidelines for the drafting of the legislation are on the way to the Chief Parliamentary Council, and that in short order, within this next financial year, Barbados would have this legislation enacted, which is something that is years outstanding. But we're not going to stop there. We have some new initiatives that we are going to be pursuing in the coming financial year. For example, a national nutritional policy, which we expect to deliver by September of this year. The creation of a Center of Excellence for Pediatric Care in Barbados, which the Queen Elizabeth Hospital team can speak to. The reorganization and restructuring of the public health, dental health program, which is struggling at the moment. The accreditation of the Best Dos Santos Public Health Laboratory, and establishing a climate change and health unit within the Ministry of Health and Wellness. These are some of the new initiatives on the table. I would anticipate some questions in relation to these initiatives, but I want to go straight to COVID because this is something that is going to be with us for some time. And I want to state clearly the ministry's response to COVID-19, and to say that the staff of the Ministry of Health and Wellness have been tracking this from January. Early January, we were monitoring the progress of this virus throughout the world. And we started by doing a program to sensitize and to train frontline persons in this country who we believe needed that training before the rest of the population, and that sensitization. And enhanced surveillance and screening, that for us was the major thrust in the initial stages. And we felt that that had to be the major effort, and it continues at this time to be the major effort in our quest to ensure that we did not have the importation of the virus into Barbados. And so far, that program and that strategy has been working very well because we've been able to enhance our surveillance and screening regimes at the ports of entry. But we've gone beyond that to the establishment of quarantine protocols for self-quarantine and also mandatory quarantine. And we have gone to the extent of establishing some facilities for this, and we are in the process of having a larger facility at Harrison Point. We've also decided to expand our isolation facilities. At the moment, there's one isolation facility located at the Enmore complex, and we are in the process at Harrison Point in expanding the capacity to be able to provide a greater coverage in the event that that is required. What we are pursuing in the ministry at the moment is the National Pandemic Plan and Protocols, and these are plans that were used for H1N1, and we have been able to adjust and adapt those plans so that they can help us to execute what is required for COVID 2019. And so we believe that these plans and the forward thinking of the staff of the Ministry of Health and Wellness will give us the capacity to be able to cope with whatever comes our way. I will say to you that for the average Barbadian and for all citizens and residents of this country, I would like to encourage you to take the precautions that have been promoted and advertised by the Ministry of Health and Wellness through the GIS very seriously, and to have confidence in the ability of the staff of the Ministry of Health and Wellness to be able to deal with this situation. And with those opening remarks, Madam Chair, I am obliged.
Could you move the head, please?
Sorry, I beg to move that head 86, stand part.
Thank you. Honourable Leader of the Opposition.
Thank you very much, Madam Chair. Appreciate the opening comments from the Honourable Minister of Health. Appreciate the presence of his team here in support of this discussion, this debate here in this honourable chamber. Now, the format for these estimates, Madam Chair, provide a very good opportunity, a platform for ministries to come and, beyond simply defending their estimates, really give public vent to the policy initiatives which the ministry will be pursuing in both the immediate and medium-term contexts in service to this country, in this case with respect to provision of health-related services. The unfortunate reality also is that this format gives opportunity for some ministers to create the perfect world by the words which they wield. Now, my honourable friend here who represents the city and who leads this ministry is not given to that type of practice, and therefore I am sure he will speak with candor. I have a question or two in relation to COVID, to which he made reference, and some other questions, but I will start with this one because it has really been apparently quite so a problem in Barbados. The matter of surgeries at the QEH. Whether we talk about elective surgeries, essential surgeries, perception is abroad in Barbados that there are problems at the QEH, the institution there, with reference to being able to properly, efficiently schedule surgeries. Some of the problems we have heard acknowledged to be systemic. Some relate to equipment deficiencies. And I am sure that the government will, as capacity allows, and in due course, give correction to that aspect of it. And we will always want to urge that that be the case. The problem beyond that has to do with the culture, which seems to obtain at the hospital, where there's seemingly a mindset among some of the senior professionals. It's almost like a culture of fiefdom that operates at the QEH. If I'm wrong, Mr. Minister, I am sure you will correct me, but one gets a sense that there is a culture among senior medical professionals, predominantly so doctors, consultants, who create scheduling chaos at the hospital by their attitudes. that is a perception held out there. This is a complaint that has been raised with me. This is not the first time I've raised it in the Parliament of Barbados, and on a previous occasion on which I did so, I was threatened by one of the senior medical professionals operating out of that institution. Scheduling becomes a problem. Then there is, in my view, misuse of hospitals' equipment for personal and private interest advancement. I say this because this is said in fairly loud whispers in the Barbadian community, and it has been said to me. And because I am persuaded that you will speak truthfully and fully so to issues such as that, I put it before you.
Thank you, Honourable Leader of the Opposition. Let me start by saying to you that I think it would be unwise of me to attempt to answer the majority of the part of the question that really relates to the Queen Elizabeth Hospital, because the executive chair's sitting next to me and she has her team. But from a policy perspective, which is the level of the Ministry of Health and Wellness, I can assure you that several months ago I met with the chair of the QEH, and I informed the chair that I was very concerned at the time, and the ministry was concerned with the situation regarding the delays with surgeries in general in Barbados at the Queen Elizabeth Hospital. And I directed the chair to get together with her team and to come up with a strategy to deal with this situation. And I had indicated at that time, prior to COVID, of course, that that was perhaps the most important thing for me for this coming financial year, because I think it was affecting a number of Barbadians. My colleagues at Cabinet every Thursday used to speak to me about it, and so I had that meeting. So I will now turn over to the Executive Chair so that she can comment on progress so far.
Thank you so much for that question, and thank you, Minister, because you have provided significant and substantive leadership in placing this at the top of our priority list. For us as a management team, and particularly since I've had the opportunity to lead the institution in its operational management, we've had to look at this issue most critically. To look at this issue, you have to separate fact from fiction. You have to look at what the data is actually telling you. You have to look at what are the organizational cultures and systems that exist within the hospital. And you have to look at to what extent those organizational systems and cultures are fostered by the absence of policy or the absence of information system and processes that can better shape how business is done within the hospital. So that is the first thing. So we can speak fairly candidly. You're correct that we have had scheduling chaos in many instances, and we've had it for historically. And every Barbadian knows someone who's been scheduled for surgery and has had that surgery delayed or bumped. Through these reasons are multifold, and I'm gonna share with you some of the reasons and what we've been doing to address them. Part of the challenge we've had is our autoclaves. Our autoclaves have been at end of life for a number of years, and therefore they have been breaking down. We've gotten to know the autoclave situation so well within the hospital. This is a problem, as I understand it, that existed from about 2015. What we've decided as a government and as a hospital management team is that we can no longer function with the existing autoclave plant, and we have actually purchased 2 new autoclaves from, is it AMSCO in the United States, that brand, AMSCO brand autoclave, which have been proven to work well within the context of Barbados. We also recognize that the autoclave challenge is also impacted by the water treatment. Our water here in Barbados is very different from where these equipment are manufactured. So we're not just purchasing 2 new autoclaves, we're purchasing a water treatment plant to go alongside. So that will help, because surgeries are canceled because we do not have the requisite number of autoclaves. We have entered the modern era where we're no longer carrying about 5, 6 decentralized autoclaves where we cannot control the sterilization processes. And like all modern hospitals, we've moved to central sterilization. So we must have modern and current autoclave equipment, and that is a decision taken by this administration, and we thank the administration for the allocation of resources. The second issue is on waiting lists and how waiting lists are managed. We're looking to lead and run a 2020 service with 1920 processes. At present, waiting lists are managed, and Mr. Harris, if needed, can speak more on this, are managed by the surgeons directly, and they determine based on the prioritization of who gets what surgery and when they get, depending on what they determine to be clinical priority. Now, that has proven to be problematic, and what we recognize we have to do as a country really is introduce information technology that will require decentralization and capture of surgical lists so that we're able to manage those lists much more effectively. I think all of our surgeons and hospital and public can appreciate that technology becomes a tool when you're faced with these kinds of issues. I'll move on quickly. Part of the scheduling chaos also happens at the level of the patient. Sometimes patients are scheduled, they eat, something happens and they're not able to have the surgery, and you're making adjustments at the very last minute. So we recognize that a pre-anesthetic clinic is an initiative that has to be introduced so that in advance of the surgeries, when people are being referred, that they can be examined in advance, and it can be recognized whether or not they have the requisite preclinical conditions to be able to be ready for surgery. Lastly, we have to look very carefully at separating how we do public and private work within the hospital. And we're looking at a proposal now that will allocate theaters to the private sector and theaters for public physicians. It may sound easy on the surface, but it is not necessarily easy to achieve, because the way the healthcare system is presently built is built on a public-private sector arrangements. Consultants are allotted 20 hours per week to work within the hospital, and the rest of time is intended to be spent within the private sector. So public-private operation within the Queen Elizabeth Hospital has existed since time immemorial. And what I believe the government has signaled in its discussions about costing, understanding what is the cost of care to deliver services, and its talk about transforming the Queen Elizabeth healthcare system into a trust, so it is separated from the private service and able to run and manage its hospital. And the discussion about changing the healthcare system in terms of how people are able to access care becomes fundamental to being able to change those relationships of public and private operating alongside each other within the facility. So you are correct to have identified that this is an issue that has to be addressed. What we're saying is that we're currently addressing it at both the information technology level, in how we do clinical screening of patients, in ensuring that the equipment, stocks, and supplies are in place so that when surgeries are scheduled, they're not canceled because the equipment has broken down. And lastly, looking more fundamentally at how public and private work alongside each other within the hospital.
Thank you, Minister. Thank you, Ma'am. And Ma'am, I heard you to say that, yes, you have scheduling chaos at QEH, especially with respect to surgeries.
Yes, Chair. It has been indicated that we have had challenges with our scheduling at the hospital, from time to time.
So you are now characterizing what you formerly called scheduling chaos as challenges.
Sir, I'm giving you an honest and direct answer as to what is happening at the hospital. I think it is well known that we do have challenges with scheduling at the hospital.
And I didn't think that you were giving me otherwise than an honest response. That is why I was bold to repeat what you said initially, that there is scheduling chaos at the QEH, which you said is caused by systemic issues, management of waiting lists, issues around the patients themselves, and then what you euphemistically characterize as separation of private and public work. But would you not, in very clear terms, acknowledge that the view held by many, that there is a culture among consultants and senior medical professionals at the hospital which suggests that they constitute an untouchable group, a group which is untouchable, that you do have this problem and that we continue to fail to frontally address it, to confront it. There are people who exploit the situation in the hospital because of their senior professional position, and we continue, as an economy faced with challenges financially, we continue to fail to address it. Would you acknowledge that, or am I off base? Well, the doctors might be hearing me, Madam Chair, and I am hearing the Prime Minister, the Honourable Prime Minister, in the aside. And you will deal with...
Madam Chair, with all due respect, if the Honourable Member wants me to enter the debate, I'm more than ready to do so. So that if he wants me to enter the debate, I can
Excuse me,
enter the
all?
debate, because he referred to me.
It was my view that I had the chair, Madam Floor.
The chair?
You have the floor. Continue, Honourable Leader of Opposition.
Well, I had politely addressed a clear question to the Minister and the Chairman, the Chief Executive Officer. And I do not know why the asides keep coming from over the aisle, Madam Chair. My question was addressed to the Minister and his team, not the Honourable Prime Minister. But if she wants to get into it, she can get into it and answer the question.
Madam Chair, on
It
a
is
point of
widely
order.
believed in
Madam Chair,
Barbados
on a point
that
of
there's a
order.
group at the hospital that
Madam
take
Chair, on a
advantage
point
of the
of
situation.
order.
And I am
Madam
simply
Chair,
asking
on
whether
a
or
point
not
of
it is the
order.
CEO's view
Prime
that this is
Minister?
true.
Madam Chair, on a point of order, the Honourable Member is free to ask whatever question he is, but he's also not free to refer to me in a way that imputes improper behavior on my part. Now, in case he forgot the rules of this Honourable House, I have the right to intervene on a point of order whenever an improper motive is being imputed. In these circumstances, I would ask the Honourable Member to focus on his questions and to leave me out of his due. I will have the opportunity to speak after him.
Madam Chair, with your leave, I may not be as familiar with the rules of the House as the Honourable Prime Minister. But I do know that if you rise on a point of order, you have to wait until you are acknowledged. And you have not yet acknowledged the Prime Minister. I don't know how she got into this discussion. Anyhow, I put a simple, straightforward question.
I did
put a
acknowledge her.
I put a simple, straightforward question to the team here, and was simply asking for an answer. If I'm wrong, tell me I'm wrong. Yes, he's poor, and he will always be poor. I'm here to serve the people's interests, though.
Thank you for the question, Honourable Member. I will answer the question by saying to you, Honourable Member, that there are a number of issues at the Queen Elizabeth Hospital, as I alluded to earlier, which I have discussed with the Executive Chair and the Board, and I've asked them to look at all of the issues and to come back to me with a solution so that the solution will be beneficial to the people of Barbados, and I await the submission of those proposals from the Honourable Chair, from the Chair, sorry.
Honourable Leader of Opposition, are you finished? You have a third question?
Well, I am not quite finished, but the Honourable Prime Minister seems anxious to interject, and I anxiously await that interjection.
The chair recognizes the Honourable Prime Minister.
Thank you, Madam Chair. Madam Chair, I'd like to first deal with the issue of equipment, and if I be guided by the rules of this chamber, I believe I have more than 3 questions. I have the ability,
You have 10 minutes to
thank
ask.
you, to speak for 10 minutes if I so choose. But I'm going to do a combination of speaking and questions. Madam Chair, this government is absolutely clear and focused on its responsibility to be able to rehabilitate the Queen Elizabeth Hospital in order to be able to deliver to the people of this country quality, reliable, and in certain cases where charges are still applicable, affordable health care. It is against this background that in addition to the QEH, we also understood that the entire healthcare system has to be brought fully into the 21st century and to be allowed to cater to the needs of ordinary Barbadians who may not have the money to be able to go to Sandy Crest, and what's the other one? FMH, and who themselves have been paying taxes and fees and services in this country for a long time. Now, we have heard from both the Minister and from the CEO of the QEH thus far this afternoon. But we are not existing in a cocoon either. And we are aware that, for the most part, a lot of the equipment at the Queen Elizabeth Hospital has been aged, has not been replaced for some time. You heard the CEO refer to the pieces of equipment that affect surgery. And the bottom line is that in spite of being in an economic adjustment program, this government has determined that we will make available to the Queen Elizabeth Hospital and to the polyclinics a sum of money to be able to purchase equipment, given the fact that much of the equipment that has been left, in some instances, without proper maintenance agreements, in some instances without being properly serviced, and in many instances beyond their life, have now to be replaced. The hospital and the Ministry of Health have come up with a list that is roughly about $30 million Barbados in value. That has now been further compromised by the prevalence of the risk, or the introduction of the risk of COVID-19 that all of us face across the globe today. It is against that background that my government has done 2 things. 1, agree that there has to be an appropriate purchase of equipment, and that the Queen Elizabeth Hospital has to be provided with those funds, as does the Ministry of Health for the polyclinic and other hospitals within the system. 2, that we also agree that the health levy, health service fee, that is being charged by or being collected by the National Insurance Scheme for the Ministry of Health and the QEH specifically, has now to be taken fully into account. As a result, it means then that we are likely to see close to $60 million being provided off budget for the Queen Elizabeth Hospital. In addition to that, I'm going to ask the CEO and the CFO to start to speak to some of the efficiency savings that they have found or capable of finding within the Queen Elizabeth Hospital to be able to allow government to be more appropriately in a position to spend its money on the areas of need. In addition to that, the Honourable Leader of the Opposition spoke to the fact of surgeries. Suffice it to say that one of the things that has shocked me was the extent to which we have not been able to have a full utilization of the surgical theatres within the hospital. And the government has determined that it has to be able to do so. And it will do so on both a pure public basis, but it also needs to start the discussions with the medical personnel to be able to allow access to the operating theatres as a theatre on a more structured basis to the private medical professionals in this country, to the benefit of all. In order for this to be done effectively, we need to have a real picture as to costs and to what we therefore need to cover in terms of giving persons access to the space. We equally need, therefore, to complete the process of costings at the Queen Elizabeth Hospital from a plaster to a major surgery. And it is against that background that in the estimates of last year that we are now coming and bringing to an end, the government provided sums of money to the hospital, which they were able to contract the University of the West Indies and eminent health economists to be able to help us in the process to do those costings. We also recognize that it is critical for us to be able to rationalize the delivery, in particular, of accident and emergency. And that while we await the studies on the future of health insurance and the funding of health care in this country, which is still not yet available, that we need to be able still to have some sense of where we are going and to start the discussions, because the work which has been done even before we came to office shows that the largest percentage of expenditure in healthcare, in fact, comes within the private healthcare economy and not the public healthcare space in this country. Against that background, we started to focus on what is absolutely essential for the government, and the provision of a well-functioning accident and emergency department within the Queen Elizabeth Hospital is an obligation of the state and not just an obligation to be shared among who can afford to go there and who cannot afford to go there. In addition to that, in these very same estimates last year, I believe that I spoke and questioned the hospital and the Director of Medical Services, I believe, with respect to the cardiology project, which in large measure is intended to be able to improve the capacity of the hospital to respond to persons with some form of cardiac arrest, what we call it, myocardial infarctions. I'm learning. And to ensure that the timelines that are critical to be able to respond to those cases can be met within the time frame to reduce the number of persons who are potentially being affected from 37 or 38% mortality rate, 37 to 38 out of every 100 persons, to what it is in the developed world, which is closer to about 8 out of every 100. That is a huge reduction that we want to achieve over time. And it is against that background, therefore, that the government has already given the hospital the money for the accident and emergency. I'd like an update on where we are with that specifically, because I believe that the hospital has been making and looking at some other decisions as to where to place it, which may not be known to the public yet, and how to reorganize their own businesses and clinics to facilitate that expansion. Two, that we are hoping out of the savings that are available from this fiscal year to be able to also give the hospital at least 2 million, possibly 3 million, and we will know within 2 to 3 weeks what we can with respect to the cardiology project, which is intended to save the lives of Barbadians who may have some form of cardiac arrest, but who right now are not getting the benefit from the ambulance right back through to the processes in the hospital to have the best possible chance of survival. Now, I remember making a statement from the other place where we were last year, that if we can do this and get the kind of results that this is what this process is about, and taking the taxes of the people of Barbados is fundamentally about. And I therefore would want a restatement of a commitment from the QEH that it understands its role in being able to get this project operational during the course of this year without prejudice. And I'm not speaking at this point to COVID-19. I intend to do so shortly, and contrary to even what the Leader of the Opposition believes, he is going to be part and parcel of that process, as well as all other stakeholders in this country. But I do believe that before addressing this Parliament, I have a duty to speak to a number of our stakeholders and then come back here on this matter. But for today, I want to focus on the QEH and the primary health care system at this point in time. Suffice it to say as well that I want a report to this Parliament about how the funds that we have provided to you with respect to the 24-hour polyclinic system at the Sir Winston Scott Polyclinic is in fact functioning, and whether it has made a difference, whether we're seeing the increased numbers, and to what extent have we eased the burden on the A&E with respect to those who can now see and receive treatment at the polyclinic, which is virtually across the road from the hospital campus. So with those few words, I'll stop at this point, and if I do need to come back, I'll come back with questions. But suffice it to say that the restructuring of what has to be done at the hospital is not going to happen, as I said, in a month or a year. And therefore, we have to stay the course for at least 3 years in order to see the turnarounds, which range from equipment to systems to access to physical infrastructure to all of the various things, to legislation even, and then to funding. And to that extent, what you are seeing is a process at work. It is easy to sensationalize. It is easy to speak from this perspective or any perspective. But to actually manage and restructure and to change a culture and to carry the people along with you is a process that requires perseverance, discipline, creativity, and understanding, because you are also dealing with a staff complement of 2,000 people. And therefore, I introduce these things in order to show that if we want to change, as we are seeking to do, that we need to be able to show what we are doing. And I invite the Minister and the CEO of the hospital to please be full and frank, in spite of the extent to which the Leader of the Opposition may be more focused on the salacious aspects of the excellent work being done at the hospital at all levels. I thank you.
Madam Chair, I object most strenuously to that. I'm not focused on any salacious aspects of anything. I didn't offer any criticism with respect to the equipment deficiency at the hospital. In fact, I said up front, I believe the government is treating that and will treat that over time. My concern in the interests of Barbadians, and this is not a salacious matter, that when you have to go to the hospital and you're scheduled for a surgery, it is postponed multiple times, or you're told you can't have it for the next 2 years, and you're made to believe by circumstances that it is because of a culture obtaining among a certain professional set at the hospital. That is not a salacious matter. That is very primary and pertinent to the interests of Barbados. And I asked the CEO
Madam-
for a response to that because she said
Madam
there
Chair.
is scheduling chaos at the QEH in response to my queries.
Madam
That is
Chair.
not salacious. I
Madam-
object to that.
Madam Chair, the doctors, the nurses, and the professionals of the hospital are not in a position to defend themselves from the floor of this House. And it is therefore critical that we do not have persons using language that is intended to inflame, especially at this point in time. And it is against that background that when the CEO refers to the systemic challenges, I've tried to contextualize it by not only speaking but also asking the questions, which I hope they will shortly answer, about what they have prepared, because if you don't have the equipment to do the surgery, because you cannot sanitize the different pieces of equipment that you need in order to do surgery, then it would be reckless, and in fact, the Attorney General might indicate it is a form then of gross negligence or criminal behavior. And it is to that extent, when the CEO therefore refers to systemic issues, that I truly believe that we have a situation that you need to give them the opportunity to explain what has been at issue. Now, this country has found it possible in the past to be able to have a well-functioning Queen Elizabeth Hospital. And I believe we can do it again. And pound for pound and ounce for ounce, our healthcare professionals, be they nurses, be they doctors, be they lab technicians, are worth everything. But what we can't have is us turning on ourselves simply because we are on different sides. We know that there's a backlog. And it is against that fact that we've tried to be able to give the hospital the resources that it needs in order to be able to reduce the backlog. And more so now, when there is the potential risk of a public health emergency. Now, language is important. And it is to that extent that the government has determined that whatever we do to meet the public health emergency must be done without in any way compromising the capacity of our main general hospital to deliver care to ordinary Barbadians at any stage of their life. And remember, Mr. Michael West should remember that precept, because he was my parliamentary secretary, I suspect, at the time, when we used the same precept with respect to the prison when it burned, that we were prepared to call in and go where no government had gone before, to call in the regional security system to help us sustain and stabilize that situation, because every Barbadian should have been able to go about their normal life. And I remember on the first press conference, using the phrase, should be able to go and buy pudding and sauce on a Saturday if they so desire. Given the fact that we are now talking to the Ministry of Health, I may have to change the analogy from pudding and sauce to cuckoo and saltfish, or not even saltfish, cuckoo and fish, steamed fish, because we don't want to add necessarily to the difficulties of the healthcare system. But suffice it to say that we recognize that the issues have been beyond, and I don't want, we are in danger of accusing one group of people to the exclusion of others, or to the exclusion of the systemic problems. And is all I'm asking us to do here today, to pause before we make the allegations. If people are not doing what they're supposed to do, well, then the QEH board has to deal with it. And the QEH board must do so without fear or favor. But to that extent, we have first to get the theatres functioning. You can't blame people if all the theatres that exist at the Queen Elizabeth Hospital are not functional. And the first responsibility is to get them functional, even if it means that we agree that 2 of the 11 or 12 that there are to be made available for private surgeries, such that the rest can function around the clock as much as possible and as is humanly possible and safe in accordance with the health regulations that they have to operate under. Minister, please.
Thank you, Honourable Prime Minister. I will deal with the 24-hour service and then ask the Executive Chair of the hospital to deal with those issues relating to the QEH. The 24-hour service at the Winston Scott Polyclinic can only be described as a resounding success thus far. For the 6-month period, July to December 2019, about 21,000 visits would have been recorded at the 24-hour service for an average of about 3,500 per month. And what is interesting also is that for the corresponding period at the accident and emergency, the number of persons visiting A&E would have been about 1,200 less than for the corresponding period in 2018. So that you can see that there's been a shift towards the accident and emergency. And I believe that these figures, towards the Winston Scott 24-hour service, and I believe the figures are certainly would have been higher had there not been an increase in the number of persons that have been going to accident and emergency in terms of repeat patients with chronic diseases and so on. So that, I believe that alone would suggest to you that it has worked very well. But even beyond that, when we established a 24-hour service, we were looking at a waiting time of about 4 hours from door to doctor. That waiting time has been reduced to about 2.5 hours. And we have received several emails, letters, and calls from persons using the service, thanking us and congratulating us for the quality of service and the fact that they don't have to wait the inordinately long hours at the accident and emergency.
Thank you very much. I'm going to respond to a few questions, and I'm going to allow Mr. Harris, the Director of Medical Services, to speak a little more closely to the issue of culture in the medical profession. In terms of addressing the issue of scheduling at the hospital and waiting list, as we said earlier, we're focused on getting our autoclaves back up, or pre-anesthetic clinic in place. I'm just trying to really address focally that the government is actively addressing the issue of waiting times and scheduling challenges that exist within the Queen Elizabeth Hospital. We have one set of surgical equipment that once they are used within a theater have to be cleaned and then put back into use again, and that can cause some challenges in terms of delays. So what I'm essentially saying to the leader of the opposition is that many of these issues are not easy issues that have to be addressed, but have to be addressed systemically. On the issue of the accident and emergency, we have had a delay in getting this project off of the ground, and this is one of the instances where a delay is actually a situation where we were being prudent. We found ourselves when we were looking at getting the project started in the immediate precincts of the accident and emergency room, when we did borehole tests in the area to build a foundation, that we found at about 70 feet or so, we were meeting clear water. It meant that in order to build and excavate the premises, we were going to be essentially building on foundation that was extremely weak and difficult. We thought it prudent to look to see whether there were other options within the compound of Queen Elizabeth Hospital that provided an opportunity to build the accident and emergency room. And as the Prime Minister has pointed out, we did a careful study of the Enmore compound at whether or not that would provide us with an opportunity to build the accident and emergency there. The challenge with that option is that because an accident and emergency room has to be connected necessarily to surgical and other facilities within the hospital, you would have had to build a bridge across the Martindale's Road, and that was completely outside of our budgetary parameters. We then explored the option of building within the actual hospital and moving the outpatient clinics on the first floor and building the accident and emergency room between the first and second floor. That would have necessarily meant moving the outpatient clinics from where they're currently located into the administrative section of the hospital, where the executive chairs, nursing office, UE administrative offices are located. However, when we looked at that option, we realized, yes, we would have been able to address the challenge associated with expanding the accident and emergency room, but we recognize that modern outpatient services require more than would have been available in the limited corridor of space. If you look at how hospitals are developing across the globe, in many instances, they're reducing the bed complement and doing an increasingly number of procedures in an outpatient or in a same-day procedure. So to confine the outpatient activity into that narrow corridor, we realized we would have been, on the one hand, expanding the A&E beneficially, but on the other hand, placing our outpatient service delivery at a detriment. So it took us then back, we did a decision tree analysis looking at all of the key variables, and we essentially settled that the best option would be to go back to our original plan, and we would have been satisfied that we would have considered all options before we put the investment that will be required to essentially sink floating pilings into that area and have the accident and emergency sitting firmly on a foundation that is strong enough to build 1, 2, 3 stories if necessary. So that is when we complete this work, and we are starting, we've notified the staff during this week, and we're in the process of public sensitization, because it will require some adjustments to how people enter and exit the hospital. And it is important first that staff understand the necessary disruption and are not reading about it in the newspaper, and secondly, that the public is adequately sensitized to the changes that are going to benefit. Once we do that, what we're going to be doing is increasing the number of stat beds that we have from 2 beds to 6, so people who are affected by myocardial infarctions and other urgent illnesses will have now 6 beds. We'll have a short stay unit with 8 beds and 4 chairs. Our minor cases unit will now have 2 beds. We'll have an increased waiting area to move from 20 to 40 persons, additional washroom facilities. We'll also be in a position to create a pediatric wing. Very often children come into the accident and emergency room and are treated in the same way. Modern accident and emergency practice and good accreditation requirements say to us that you must provide in a special way for pediatrics and children within an emergency setting, so we'll be able to accommodate 10 children within the precincts of the accident and emergency room. So that build has started. The planning and laying out of the road works are going to be starting next week, and we expect that project to be completed very early next year. Our aim is to bring that project on time and within budget to be able to meet the requirements. So we're very appreciative of that investment in emergency services and in the A&E team within the accident and emergency room. We also recognize that to fix the issues in the accident and emergency room do not just require an investment in capital facilities. Though important, we recognize that as an institution, we ourselves create challenges for the accident and emergency room in the way in which we operate and manage the other parts of the delivery of the hospital services. So what we recognize that in addition to addressing the infrastructure changes, we will also have to be increasing the number of physicians and staff within the Department of Medicine, and that is underway. We're also doing a comprehensive rationalization of medical staff across the hospital. We have some areas, for instance, we have one interventional cardiologist to serve the entire country when our burden of disease, of heart disease, is extremely heavy. We have two persons who are doing endoscopic procedures, when we know, therefore, we have a waiting list that is backed up, waiting to see those two physicians. So we recognize we have to increase and do some rationalization of our physician and paramedical services in physiotherapy and other areas of the hospital to complement the increased demand that has been placed on the hospital. We also need to bring an additional number of beds into the hospital. We have been working since 2017, 2018 to look at our bed complement within the hospital, and by the end of March, we should have an additional 16 beds available in the B8. We also recognize that having increased numbers of beds require us to have an increased number of nurses. This is perhaps one of the greatest challenges that has confronted the Queen Elizabeth Hospital, because we're not able to open all of our beds within the medical intensive care units and across the cardiac catheterization suite and other areas of the hospital. During this month, we will see 63 nurses arriving from Ghana, and another 29 have been hired. Barbadian nurses have been hired between the start of 2019 and present, including 16 who have applied to us from the Barbados Community College. And we are very appreciative of the Ministry of Education and the Barbados Community College for being able to address the challenge that they were faced with getting nurses to pass the examination, and were able to take most of the nurses who have applied to us in that program. We also recognize that some of the nurses who have had challenges passing the nursing exam are nurses who are in need of mentoring and support. We have included positions of graduate nurses within the hospital complement to be able to give them the necessary training and investment. So we are looking, and the government and the hospital have really invested in strengthening the number of nurses available within Barbados, not at the Queen Elizabeth Hospital, and the minister will speak to the wider health system. We also recognize that bed management in the hospital has to be improved. We're currently recruiting a bed controller to really look at how we use beds more efficiently and have beds ready and available for patients, so there can be more efficient movement from the accident and emergency room into the beds, which can be a challenge within the hospital. But most importantly, part of the inefficiencies affecting the accident and emergency room are how long people are actually staying once they're admitted to the beds. People are staying in beds for extended periods awaiting other diagnostic and clinical services. So we're inducing new length of stay and bed management protocols, so we'll be able to better manage and monitor patients, so we recognize and red flags go up when patients are staying too long in beds awaiting procedures that they should be able to receive much more efficiently. We also recognize, although we are doing things within the hospital to strengthen how we do deliver care within the hospital, there are projects that the Prime Minister has mentioned in her question, so I'm providing an update here. In addition to the 24-hour polyclinic service, which has done a tremendous job in treating non-urgent cases that were otherwise coming to the Queen Elizabeth Hospital, we're in the process of rolling out our community health worker project, where we recognize that there are many patients within Barbados who are cycling in and out of the Queen Elizabeth Hospital because our discharge planning processes are weak, and we are in the situation where when persons are discharged home, they're not necessarily getting the necessary social and clinical supports. So we are rolling out a project led by the Social Work Department of the Queen Elizabeth Hospital, which will see us tracking 50 patients who are known to us to be challenging to really reduce the cycle of persons being discharged and coming and cycling back in through the hospital because they're unable to get the clinical and necessary social support at home. We also recognize that the burden of heart disease is extremely high, and our cardiology project that was announced at the last in the last time we were in estimates, the Prime Minister would have announced that we will be looking at having a national cardiology project. This has been discussed at the level of the heads of government, that there needs to be a national program around the delivery of improved cardiovascular services across the board. We have earmarked our Director of Medical Services, Mr. Tony Harris, to provide that necessary national leadership to be able to roll this project out. So we have the resources, we have the plan, and we're putting the project coordinators and other necessary support staff to be able to roll this project out across the public, private, and NGO sectors. We also recognize that there needs to be necessary investment in the primary healthcare model and the prevent health promotion elements of the Ministry of Health. And the Ministry of Health has been working actively to strengthen this area of their service delivery. And I'm pretty sure that the Minister will speak to this as he and his team talk about what is happening within the primary healthcare system. So that is a quick update on what is happening with the accident and emergency room and the two projects around community health support and cardiology. I'm going to allow my Director of Financial Services to speak briefly, because what we've been working on at a hospital to whom much is invested, much is expected. And we have been able to benefit from the health levy, which has performed extremely well in the last this current financial year, and is expected to continue to perform pretty strongly. And in this regard, we have taken it as a specific mandate to essentially strengthen areas in which we can find specific efficiencies. We have recruited a new finance manager, Adrian Hurley, and within the first 2 months of his joining the institution from the private sector, he has been able to identify areas that we can distinctly find efficiency savings, and I'll let him have a quick opportunity to highlight that for you.
Good afternoon, Chair. Like my chair just said, within my first 2 months, within my first 2 months on the job, my first task was to basically analyze the operations of the QEH. And the reason I did that is because my chair had indicated that our budget might have been cut in this coming financial year, and therefore we would have need to look for cost savings and revenue generating opportunities to supplement our operations. We are in the process of implementing an inventory management system at the QEH. Right now, the process of ordering and procuring medical supplies is erratic, currently a little disorganized. This is resulting in some cases we are ordering too much of one thing and too little of another. It is also, and this results in us having to make emergency orders, which means flying them in and incurring additional cost. We've rolled out the information systems this week. We are doing a pilot in accident and emergency. Then we will be moving to pharmacy, and then we will be moving to the lab. We have a two-week pilot in accident and emergency. It is believed when the full rollout is done, we will save We are currently spending up to date about $26 million, $27 million in drugs and medical supplies. And the conservative estimate of savings after the implementation of the inventory system is about 10% of that figure, which is about $2.7 million. We also expect to have a reduce the levels of drugs expiring and obsolescence, and our conservative estimate of that is about $500,000. We've also found some contracts in place which we're reviewing. One in particular is the rental of printers at a sum of $14,000 a month. That is under review, and which is a total, which is going to be a savings of $176,000.
Renting printers for $14,000 a month. That's
Pardon?
what he said.
There's currently a contract in place for the rental of printers with a total of $14,000 a month. We're currently reviewing that, bringing that contract to an end in this month, which is going to be a savings of $176,000. We also have an issue with our morgue. Our morgue is the capacity of our morgue is an issue, and as a result of this, we've uncovered a situation where we are currently outsourcing the storage of corpses at a private morgue at a tune of $35,000 a month. The issue is that the management of our morgue needs some attention. What seems to be happening is that the short stay corpses are staying at the hospital. Yeah, so those persons with families, yes, those corpses, these are considered as indigent. Those persons that are not claimed, and persons and which they need to be claimed by the welfare department. Those corpses are being outsourced. Therefore, we're incurring a cost of $35,000 storage fees of about $35,000 per month.
Mr. Hurley, I'm going to halt you a minute because both of you went way over the 10 minutes.
Sorry.
3 minutes, sorry.
Sorry.
I know you would have answered several questions, but I want to get in some questions from our members, if that's okay. Let's invite questions from the member for Christchurch West.
Thank you very much, Madam Chair. And I have 3 distinct questions to ask Minister, and I guess by extension you will give way to your particular members. The first has to do with bed management. And I recognize, and I think we all know, that there's a big problem with members of the public bringing their elderly relatives to the hospital when they can't get a particular bed at the geriatric hospital, and leaving them there until a bed becomes available at the geriatric hospital. And obviously this is a big problem because then it takes up a bed that could be used for a person who's generally ill, and instead is being used as a waiting facility for the geriatric hospital. So I'm wondering, what plans do you have to be able to fix this problem so that more beds will become available rather than beds being used up as a waiting policy to get into the geriatric hospital?
Thank you, Honourable Member. This situation really is part of a larger problem. I think that we all need to recognize the fact that Barbados is an aging population, aging society. And to be honest with you, we've been working closely, the ministry that is, with the Queen Elizabeth Hospital to try to reduce that burden by taking those persons out of the QEH, and we've done it more than once, and having them located within the elderly healthcare facilities, including the alternate care, the elderly program. But the truth is that the demand for spaces within the elderly care institutions is greater than the capacity, and it's something that we have to address. I've already spoken to my colleague, Minister Ford, Cynthia Ford, who has a responsibility also for elderly care, to see how the two ministries can combine to deal with this issue. But it is a problem, a growing problem, and I don't think in a lot of cases it is that all the relatives are not necessarily leaving the elderly behind. I think in some cases we've seen people with who are cases for dementia cases, and we need to do more as a country in terms of sensitizing families as to how to deal with patients, relatives, who are suffering dementia. And there are a number of problems associated with this that have to be dealt with, but I think it will take the two ministries coming together to be able to resolve those issues.
Thank you very much, Minister. Clearly, it's something that needs attention, and it's because obviously a bed in the hospital costs significantly much more than a bed at the geriatric hospital in terms of the care that is given out and the cost per bed. So it's something that I think that if you get a handle on it, you get significant savings and then make more beds available for people who are genuinely ill. Not that they aren't ill, but certainly who need more intensive care. The next matter that I want to bring to your attention and ask of, last time we were in this chamber, I obviously brought to the attention the issue of corruption in the Queen Elizabeth Hospital, and in particular procurement and the problems associated with procurement and middle companies and so on and so forth. What have you been able to investigate any of these, and what have your investigations revealed with respect to procurement problems in the Queen Elizabeth Hospital?
Thank you very much. The issue of procurement challenges has occupied the attention of the Board of Directors of the hospital. We are currently collaborating with the Attorney General's office, who has been rolling out a process of examining corrupt practices, not just at Queen Elizabeth Hospital, but across the entire public sector. And we have provided all of the necessary information that we have been able to glean before our ability of our audit committee and our ability as a board of the areas that we suggest that we look at in terms of possible areas where there may be challenges. We recognize that, however, beyond looking forensically at what has happened in the past, that we have a duty to really correct and make right our current and existing practices at the hospital. So we have looked at completely restructuring the procurement department. The procurement department, first of all, was brought under the finance department. That is a basic and fundamental of most entities, that procurement is controlled by your financial management system. We've also brought in a team of consultants who are looking at digitizing our procurement processes and making them more efficient. We're also looking at how the building capacity of the staff within the department to be able to understand better the needs of clinical service delivery. So it is a complete re-engineering of processes that has been underway within the engineering department, so we no longer have those issues, and we also have the checks and balances of the finance department. I'm really leaning more heavily on how items are procured at the Queen Elizabeth Hospital. We are putting in place and we have put in place and approved vendors checklist. So we're doing all of our necessary due diligence on both local and international vendors, so that we know that the vendors that we're doing business with are legitimate vendors and are those vendors that we can be comfortable as taxpayers that we can purchase items from both locally and internationally.
Just Clearly, your emphasis on legitimate vendors obviously tells me that in the past you were dealing with some illegitimate vendors. I think that is clear. But I won't ask you to get into that. Obviously, it is something that may be sub judice, and I appreciate that. The final question has to do with the response to COVID-19. And I just wanted to know, what plans does the hospital have in place for suspect cases of COVID-19? I'll give you an example. Say a person has been to an area that the COVID-19 is prevalent, China or Hong Kong or Korea or wherever, and then they find that they have symptoms. Are those people to come to accident emergency or urgent care, or are there special plans in place for somebody who suspects that they might have symptoms?
The policy, and we are going to be doing some work on this in terms of public service announcements. We, as a ministry, we would rather for persons who may be feeling ill, or persons who feel that they may have the symptoms of COVID, to call a hotline which we will establish or we will give notice of shortly, or call one of our polyclinics or facilities, but not to report to the hospital, because we would want to treat that person or those persons in a different manner so that it does not compromise the safety and integrity of the hospital.
I have one question on that. I've now seen the protocol. Somebody just not too long sent me the protocol for general practitioners, private doctors on the outside. Did I miss it, or were we invited to learn about this? Because the truth is, not everybody goes to the hospital with a cough and a cold, and most people don't. We are, as you said, primary care, and this is where they turn up. Did I miss a meeting or a conference? It could have been on me.
You might have, but I am going to hand over to the Chief Medical Officer, who is the person with the authority to speak.
Appreciate it.
Thank you so much, Madam Chair. Yes, I agree with the Minister that the most ideal place for a person to present is not the accident and emergency. However, I'll be very frank. Yesterday, there was a potential patient who interacted with the emergency room, and I was convinced that the necessary precautions were taken. It was handled in a way that was highly professional. The testing was done, the tests were negative, and the patient was discharged.
This was a patient coming in, or a
Yes.
patient already on island?
Yes.
So who would have sent him to the hospital, him or her to the
I
hospital?
think the
Through
person
airport, or-
self-presented to the hospital.
Okay.
So the person instituted that. So it's not ideal for persons to come to the hospital, but they have a way of dealing and containing that situation. With respect to your other question, the question was what?
The question had to do with doctors.
We had, at a cost to government, brought BAMP on board. We were hoping to get 80 individuals to come and hear about COVID.
Many of us are not members of BAP,
Right.
including myself.
And we also invited the pharmaceutical agencies. And unfortunately, the outcome for that was quite poor. We only got 20 individuals attending. However, BAMP then yesterday hosted a forum, which was a much larger public forum, and I'm happy to report that the Ministry of Health was first involved in that process. And secondly, they were able to capture a greater number of physicians, both BAMP and non-BAMP. We agree that there is much more work to be done with respect to sensitizing physicians in this country. Because I will tell you what, if it becomes that COVID becomes very widespread in Barbados, 80% of those cases will have to be managed by persons in primary care, whether it be in the polyclinics or whether it be in the general practitioners, and that's why we're urging the general practitioners to come on board. We've issued a few guidelines for them because there was a lot of uncertainty, and we issued those guidelines as to how they can manage to deal with a case if it ever comes to their private office in a way that contains the whole issue.
Thank you. We are gonna, all done. We are gonna move on to the honorable member for Christchurch West Central. Let us save most of the COVID questions when we continue next week. I'm asking politely and nicely because I've been directed. So if you have any other questions, feel free to ask.
Thank you, Madam Chair. I want to thank the Minister for his presentation, obviously, and for bringing a military approach to healthcare in Barbados. Certainly, unlike your predecessor, you don't have a plan of action, but certainly an action plan. And I want to say that last year, I came in this August chamber. I came in this chamber and I asked about the nurses, because there were two in my constituency, and me and the Member of Parliament for Christchurch South will always rival as to who has the epicenter of Christchurch. I would say the epicenter is the center, Christchurch West Central. And the question from those nurses in my constituency is that they were having challenges passing their exams. I'm happy to hear from your people, your officers, that there is now a new system put in place, and the results have shown that there have been a tremendous improvement, up to 60% or so, and I want to congratulate you for that. My question to you, though, Minister, is, and you can probably direct this to the Director of the Drug Service, and I want to thank her. I want to thank her for her action plan as well, because every single time I call her about the issue, she's able, ready, and willing to respond to the issues that are confronting this country as it relates to the drug service. My issue is that we are faced with a problem now in this country as it relates to the purple drink and the lean. We have regulations that date back to 1993, which has not been updated. And with the new problem that we are faced with, I want to know from the drug service what measures are being put in place to ensure that this problem, that we at least are able to dry up the supply of these products, because right now, the mixture, the simple mixture to make lean is codeine linctus, which can be purchased off the shelf by any individual, whether it is intoxicated linctus or any of the other cough preparation. My issue is, what is the drug service going to do? What the drug service is going to do in terms of the regulations, and how do we intend to ensure that these drugs are not accessible to the average person?
Thank you, Honourable Member, but I want to provide the answer to your question, the first part of it, that is, and to say to you and to all honourable members that this is not a problem for the Barbados Drug Service. This is a problem that is being addressed and has the attention of the entire Ministry of Health and Wellness. And I can say that this matter has been discussed at the meetings of the Drug Formulary Committee, of which the Director of the Drug Service is a member. It has engaged the ministry, and we are going to be coming up with a plan, a ministerial plan, to be able to deal with it, but I will allow the Director of the Drug Service to go into the specifics.
Thank you, Madam Chair, for the opportunity to speak, and thank you, Minister, for the opportunity to speak on these topics. First, let me say I thank my former student who has these beautiful questions for me to ask. And I'm sure that he's aware, because we are working with him and his ministry, and also with the Minister of Home Affairs, to address some of these challenges that we have noticed that have been affecting our children. And when I say our children, I don't mean just in Barbados. I think it had been a regional issue, because the Bahamas, they had also sometimes last year requested us to assist them because of their children using codeine and mixing them with all kinds of things, to make drugs that they think is beneficial to them, which of course they have soon found out that it wasn't. And because of that, we have been planning training. We were focusing on our drug inspectors, but we have decided that we are going to train a cadre of pharmacists. So we're planning training for about 25 pharmacists from March 3rd to April 7th, and we are going to be working a lot with them on new psychoactive substances, how it is made and so on, and also how we are going to be going about going to places where these things are sold, to be making sure that they're regulated and they're sold according to regulations and whatever is there. And in terms of legislation, what is being done currently, I agree with the member for Christchurch West Central that the legislation is outdated because of the 23 chemical precursor substances that can be used to make these substances. Barbados, we have only 12 in our legislation, which was made since 1988. And since then, we have needed updating. And we have been working with the National Council for Substance Abuse, and we have been looking, and in fact, they have provided technical assistance through COPOLAD, which is an EU program that we have actually come up with a model legislation that will address these issues and that will bring all the chemical precursors up to date and also make provision for newer ones, because with chemicals, if there are no chemicals, there'll be no drugs. So with the chemicals that are coming up, we are now getting ourselves ready that we will know of them well ahead of time and that we would be able to grandfather clause all new things that come under that our legislation would be up to date. And I don't want to blame COVID, but the Minister for Home Affairs was just asking me 2 days ago where we are with the legislation, and I did mention to him that because my attention has been dedicated so much between COVID and drug service, I've not been able to do that. But it is something that will soon be submitted to Cabinet for consideration, but we have been working on it to update it and to make sure that we are on par with stringent regulatory authorities.
I want to thank you, Ms. Hines. Certainly, I didn't want the whole of Barbados to know that you were my former teacher, but there's a saying that the good teacher teaches, the great teacher inspires. And you have now given me added inspiration to continue this fight for our young people, so I want to thank you for that. There's one other question, and it will probably go to the director of the psychiatric hospital. I had a situation in my constituency recently where a young man who was suffering from a mental challenge and his parents put him in the hospital for observation, was able to walk out the hospital and almost committed suicide. I want to know what are the procedures in terms of making sure that persons, when they go to that facility, have the type of supervision that is needed so that they won't be a threat to themselves and certainly the society. So I want to know what the procedures are in place when you go to the psychiatric hospital to ensure that there is that measure of surveillance that is so desperately needed.
Good afternoon, Madam Chair. Good afternoon, Honourable Member. Sorry. I'm Dr. Brian McLachlan. I'm the Senior Consultant Psychiatrist of the Psychiatric Hospital. If I'm to understand your question, you're asking as to what is in place from a security standpoint with regards to...
What I want to ask is that I want to know how easy or how difficult it is for persons when they are supposed to be supervised in the psychiatric hospital. It seems like if they are easy, there's a way that they can just easily walk out the hospital without having to report to anybody or having that security surveillance. So I want to know what are the measures put in place to ensure that that person is taken care of in a way that is expected in a mental facility.
When persons are admitted to hospital, then there is an assessment that takes place, in the assessment unit where they're likely to come through, and then an assessment that takes place on the actual ward that they have gone to. And that assessment speaks to many things, obviously the diagnosis, the degree of illness, as well as the what's going to be required as far as security is concerned That is, what are the concerns as to whether or not the person is going to walk out? As you can imagine, there's some persons who bring themselves to hospital, and who wish to be there. There are others who have little to no insight, and so once they're brought, they are looking certainly to get away. Where it is that there's a concern that the person is unwell and the person requires supervision, then the person is then nursed closely. I can't speak to the specific circumstances of who you're referring to, but persons are kept under observation, and the degree of observation is a product of the illness and the concern as to whether or not the person is wishing to escape or is wishing to leave.
I don't get it then, that the person can sign out. What's the process of signing out? That's what we're trying to get at, because it was made clear to me that the person was able to sign out themselves from the hospital. So I want to know what is the procedure there.
Well, signing out of oneself usually occurs when the person is voluntary. If the person is going to sign themselves out. If persons are brought into hospital involuntarily, then there are a couple of ways in which that can happen. Persons can be picked up by the police, and on the advice of a mental health officer who determines that that person is unwell, then the person comes in under what we call a hospital order, but it's most commonly known as an emergency order, and that allows 72 hours for the person to be brought into hospital where they're observed, assessed, and so on. Persons can be made what we call medically recommended. That's often how persons come to hospital, to the psychiatric hospital, through the Queen Elizabeth Hospital, where a relative or guardian or someone associated with the person would sign, and then two doctors would sign to say that the person needs to be in hospital. And that's an involuntary admission. And in that process, a person can stay in hospital for up to a year. We also have persons who are remanded from the courts, and once you're remanded from the courts, then actually that's an involuntary admission as well. Only the court can determine that that person is to be discharged from hospital. In the particular circumstance, then, the issue would be whether or not the person came into hospital and signed themselves into hospital as a voluntary client. If a person is a voluntary client and they wish to leave hospital, then either one, they need to give 24 hours notice of their intention to leave hospital, and during that 24 hours, if there is a belief that that person should not leave hospital, then that status can be changed and the person can be made an involuntary patient through the medically recommended process. If it is that the person is deemed to be well enough to leave, then the signing of "I'm discharging myself from hospital," that's when that can occur.
Minister, I would like to suggest to you, because you obviously think that there's an issue here, but for the sake of confidentiality and also to help us to be able to fill a gap if there's one, I would suggest that we talk privately so that we can fully investigate this matter, and I think it will be beneficial to the psychiatric hospital and to the public if we do it in that way, and to the person.
Minister, and I'm sorry to do this to Mr. Hines, but I want to follow on something the Honourable Member for Christchurch West Central had asked with respect to control of drugs. I'm a member of the Pharmacy Council, and we've been fighting for a little while to get steroid creams, for instance, off the shelves of cosmetic stores. We go in, we retrieve them, police escort, we retrieve them, and after that, 2 weeks later, they're back on the shelf. And the thinking is that we do not have enough teeth to prosecute. I just want to be clear on this, because this is a recurrent problem that I've been witnessing probably, over the last year maybe. We raid, take off all the creams that are just as dangerous to some extent as the ones the Honourable Member spoke about. What is there for us to do?
Let me take this one. It is a very good question, and I can assure you that we have discussed this matter not only at the Ministry of Health and Wellness, but this was actually discussed in Cabinet. And I suffice it to say that we are looking at the whole situation regarding cosmetic or beauty stores and what they are selling in terms of products that ought not to be sold, in our view, openly by such an establishment. And we have been in discussion too with the, well, I had some general discussions with the Attorney General on it. But, and we're looking at this entire thing because we have to take some action fairly soon. I know the drug service has been going out and conducting some raids with the Royal Barbados Police Force, but those raids have not really been as effective as you would like, because as soon as you turn your back, they're back on the shelves. So we are looking at a stronger mechanism and a better way to be able to do it, because some dangerous practices are developing.
Can we prosecute, or that's not on the books yet?
That is being considered, but I am not in a position to say that at this stage. We are certainly looking at all aspects, and we will take some decisive action fairly soon.
Okay. Want to say something?
Thank you, Minister. And Madam Chair, just to add, yes, as you would know, on the council, recommendations have been made to the minister with respect to strengthening Pharmacy Council to be helping. And Pharmacy Council had been helping with the raid, and there is a recommendation which has been approved in the ministry already, going forward to strengthen the Drug Inspectorate with respect to the work that needs to be done. And also to say that part of the training, because unlike different other regulatory authorities, the inspectors with pharmaceuticals, whenever we have anything that is of criminal nature, we cannot prosecute. We just hand it over to the police. And the training that I mentioned from March 30th to April 7th, it is going to include training of conducting effective raids and the procedures of following up, and also involving the police. And the police themselves, they'll be assisting us in part of the training as well. So we are looking at all of those things to try to bring them. I think once one person is persecuted, I think they will learn a lesson. Right now it's because nobody is being persecuted. Prosecuted. Thank you. Sorry, I don't intend to persecute anybody. I think once one person is persecuted, the others will take a lesson, and that will kind of bring it into order. It's because we're doing nothing and they know that we don't have any teeth. That's why they continue to do that.
Thank you.
Madam Chair, I beg to move that you do now report progress to His Honor the Speaker and beg leave to sit again.
Seconder? The question is that I do not report to the Honourable Speaker progress and ask for leave to sit again. All honourable members in favour, please say aye. All honourable members against, please say nay. Methinks the ayes have it.
Chairman of the Standing Finance Committee has supported progress and requests leave to sit again. Honourable Leader, Government Business.
Mr. Speaker, I beg to move that the House be suspended for 10 minutes. 10 minutes.
The question is that this honourable chamber be suspended for 10 minutes. All those honourable members in favour, please say aye. Those against, please say no. This honourable chamber stands suspended for 10 minutes.